the reason that I'm here again to represent the private payers is because as we started talking about payment transformation, it became pretty evident that it's difficult to do when it's done in a piecemeal fashion. There have been several medical home initiatives, several other kind of payment transformation initiatives that have been attempted by a single payer or by a single clinic or by some subcomponent of the delivery or payment system. Those are very difficult to manage because no one payer represents majority of the volume in a medical practice, and when that occurs, the incentives by any one payer really can't justify the kind of change in process and culture that needs to occur in something like a patient-centered medical home transformation. And so the reason that this is a public-private initiative is so that we can begin to have discussions about creating similar expectations, similar measures, so that the delivery system can focus on a single goal or a single set of goals, as opposed to taking a look at, well, what kind of coverage does this patient have, and so how do I need to treat this patient differently, whether it's a pre-authorization or what's the formulary or what are some of the other incentives that I have based on this patient's coverage. So as we try to create consistent measures and incentives in the system, we hope that it's going to be easier for the delivery system and create more efficiencies in procedures over time, because you don't have to spend that time trying to understand the rules for the payer that's tied to the patient that comes in. The slide that's up here today is one that I feel kind of bad going over because Andy Allison does this one best, so I'll try to do a kind of the way he does it, and that is to say that if I had 3 minutes with you today, this is probably the only slide that I'd be up here talking about. And the reason for that is one of these things is going to happen. And it's been said before that a system is perfectly designed to get results that it actually gets. And if you look at the rate of cost increase and cost escalation in medical care over the last 10 years, I think everyone's come to agree that it's unsustainable. So to try to continue on with the current fee-for-service methodology means that one of the things below the top box is going to happen. And we're here to tell you that this is really not about trying to reduce payment levels to manage cost. It's not about trying to shift the risk or throw the ball over the fence to somebody else and say, well, it's not my problem anymore, it's your problem as far as the cost. It's not about additional mother may I. Those of you who are providers in here that treat Blue Cross patients, you probably love that National Imaging Associates pre-authorization for high-tech radiology, right? Probably not. And that's one of the other options that could happen if we didn't try to create different incentives or just eliminate coverage of certain things that we've covered in the past. Those are not very good options in our mind, and we would rather try to do what's at the top, to transition to a system that creates financial rewards for better outcomes and creates incentives for team-based care as opposed to payment for the volume of services being provided. Let me talk a little bit about the broader Arkansas Payment Improvement Initiative. We're here today to talk about patient-centered medical homes, but patient-centered medical homes is only one component of the payment transformation initiative. You can see there that the triple aim is what we're trying to achieve here, and that's, as Joe said, improving the health of the population, enhancing the member experience or the patient experience, and trying to get a handle on the cost of care. And how we are going to do that is really twofold. You'll see there in the middle where the medical homes and health homes are also paired with episode-based care delivery. The responsibility of the medical home is to manage a population, a defined population of patients, to keep those that are healthy, to keep those who have disease, to manage those diseases, and then in situations where someone requires a higher level of specialty care, to make sure that they have the tools and the information to make sure that that person goes to the place to receive those services that represents the very best value, meaning the best quality, and the most efficient cost. Another part of the medical homes is to try to identify services that maybe are referred in the past and really don't create a whole lot of improvement in the patient. For instance, there's been some discussion about spinal fusion surgery, just as an example. There are a lot of very successful spinal fusion surgeries that are done where the outcome is exactly as the provider intended it to be, only to find that the patient comes back to the primary care office in 4 to 6 months, and there's really no improvement in the quality of the patient's life. So, in those situations, could there have been an alternative intervention that could have been just as successful and maybe less expensive? It's those kinds of things that patient-centered medical homes are really designed to achieve. And it's going to require that primary care physicians play a little bit different role than they have in the past. They're going to have to be more managers of the health of a population as opposed to being the provider of care for services that might be very effectively done by someone with a lower level of expertise in the best interest of keeping that population healthy and making sure that the efficiency is also there tied to the quality. Now, there are also 5 broader aspects of the program. Results-based payment and reporting. Those of you who have been involved in episodes know that we are producing reports that are different and in a lot of ways better than we ever had from a management perspective as payers. There's also healthcare workforce development that's going on. ACI, Dr. Thompson's organization, recently did a study of the healthcare workforce in the state to try to identify the assets that we have in the system to try to make sure that those assets are used most effectively. There's also the health information technology adoption under the SHARE program that's going to be the health information exchange. That's going to be key in helping people understand that if they're treating the same patient, they have access to the records that show them what kind of care that person has received throughout the medical system, as opposed to just operating in a vacuum and only knowing what you did in your particular office. Consumer engagement and personal responsibility is probably the most difficult part of all of this. Time and time again, we go out and talk to patient-centered, or we talk to primary care practices, and they will say, I totally agree with what you're talking about. It's exactly the right thing to do, but to the extent that you don't give me a compliant patient, I don't see how we can make it work. And that's very true. I think it's incumbent upon all of us to try to find out what the most effective way is to make sure that the patient holds up their end of the bargain. Payers can do it through benefit adjustments. Providers can do it as a manner of proactive outreach to the patients. So there are a lot of different ways that we need to work together to try to gain the patient's acceptance of care plans. And then expanded coverage for healthcare services, which is what we talk about as far as the Affordable Care Act and the exchanges and the subsidy that's going to become available in January by the federal government. You all probably know that there was a vote held today that got us one step closer to potentially Medicaid expansion through the exchanges, and that would serve to expand coverage for healthcare services. So there are a lot of very interesting things going on right now, and I think the timing is right for this payment transformation initiative, and I think it's very important that we all work together and make sure and communicate, because no one leg of the stool can get it exactly right. If we don't talk about this together and make sure that we devise a plan that's going to work for all of us, I don't think we'll be as successful as we could be.
The breadth of the payment improvement initiative was always this big. This slide has been a part of all of our presentations for payment improvement since I've been a part of it the last nearly 18 months. But not until now have we moved from the left-hand side of episodes and condition-specific payment reforms to the right-hand side. I have this backwards. From the right-hand side to the left-hand side. It's a little while since I've looked down. To population-based payments, person-based payments, really payments based more on a broad set of outcomes. I want to show you another picture of the patient-centered medical home of payment improvement. And I want to take this picture really in two completely different ways. One, as a picture of the health system and how it interrelates and works together. Secondly, as a depiction of all of the costs associated with healthcare, and relate those two as they hopefully should always have been related. Right now, they're really not. So this is a picture of the primary care physician in the center, in the heart, which is where we're heading, and of course with the patient and their families, surrounded by the other services that are provided as a result of that referral or that direction, or that are simply provided as a part of the healthcare system, sometimes now independent of primary care in the middle. And so imagine that this is a Venn diagram. For those of you familiar with that, just think of this as a representation, the full space that you're looking at here of all of the patients in the system. Some patients receive both services here and services from community support. So for those of you not familiar with the Medicaid program, think of community-based services, even long-term care, the full extension of long-term service and support and medical care. We have hospitals, of course. We have ancillary services. We should have pharmacy up here. We have specialists. Imagine this is all of the dollars and all of the people. Now, what does a patient-centered medical home mean practically? You're going to hear more about this from physicians, which is whom you should hear this from. And let me just give you my brief depiction. It means communication and relationships, even referrals between the primary care physician and other components, other providers in the system, obviously specialists, but others as well. It means data flowing between the primary care physician and these other parts of the system. It may mean that there are support staff, even non-providers, if you will, who are a part of the team who aren't pictured up here right now, who aren't yet part of the system because they're really not part of Arkansas's medical care provider community yet, though they should be because they help to create that link between the center and where most of the care takes place outside of the center. It means access across the full access to a coordinator in the middle, access to specialists or other services around that. Less than 5% of Medicaid spend as one payer participating in this. Less than 5% spent in the middle. In terms of health services, 95% or more outside of that center category. And yet, what we're depicting here is some relationship between the primary care provider, the patient, their family, and the full spectrum of care and services being provided. Now, that's a little bit of a mismatch. We want primary care at the heart of 100% of what goes on. What they receive is less than 1/20th. Now, I'm trained as an economist. Mostly we have, fortunately, physicians at the table, and Steve. So I can't tell you exactly how to do your job. Don't want to. But here's what I can tell you from other professions. Okay, you don't pay everyone by the hour in other professions, do we? When you pay someone by the hour, what typically goes along with that? Very specific instructions on what they're to do. When you pay someone by the hour, who's responsible for the product that gets created? The hourly worker? Rarely. Rarely. That's not how the rest of the economy works. Those who are responsible for the outcome, wholly, fully responsible for the outcome, rarely paid by the hour. That's not how you. Now, number two, someone paid by the hour. Do you typically ask them to play a directive role, a managerial role, a coordinating role? Do you ask them to take responsibility for outcomes? No, I've just described to you either management or ownership, and there are lots of theories about how you pay between the stockholder and the CEO of a company, for example. If you're entrusting capital in a company, how do you pay them? Almost always, what is it a combination of? Salary and incentives, stock bonuses. There are all kinds of theories about how to do that, but it's almost always a combination of those because they play a coordinating role. And yet, how do I currently pay for primary care as a representative of the Medicaid program in Arkansas? By the hour. So there is no rate of return to the investment for all of the connections that I described between the person that we genuinely want to coordinate and the picture of what's to be coordinated. Okay, this ain't textbook. This is textbook of how to do it wrong. And we're calling foul on ourselves as payers to say that for the entirety of the Medicaid program, and for the most part, fee-for-service insurance, we have been paying incorrectly for the very heart of medical care, and we're setting about to fix that in a big way.